Good day, everyone. Welcome to today's national webinar presented by SAMHSA's GAIN Center with the support of SAMHSA, which is the Substance Abuse and Mental Health Services Administration. Today's webinar is titled Mitigating Crisis with Presence, Developing Mobile Crisis Response to 988. The presenters today are Dawn Peel, Lori Cox, and Julie Phillips, and I will introduce them shortly. My name is Erica Ihara. My pronouns are she, her. I am a project associate at SAMHSA's GAIN Center and Policy Research Associates, which is located in upstate New York in the city of Troy. And for those of you in the audience, if you'd like to introduce yourself, please use the chat box feature to let us know where you're joining from today. And before we start our presentations, I have some introductory items to review, just a few. First, our disclaimer. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. So if you have any questions for the presenters, please use the Q&A pod, which is found at the bottom of your screen. And at the conclusion of the presentations today, we have reserved some time to address as many of your questions as time permits. And we will also be conducting a couple of polls throughout the event, and we do appreciate your participation in these. So when you see a poll pop up, if you'd like to enter your information, we do appreciate hearing from you. And the first one should have just popped up on your screen. And we'll be sharing the results from that in just a couple of minutes. So today's webinar is being recorded. The slides will be disseminated to all registrants following the event, and we will also notify you when the recording is posted to SAMHSA's YouTube channel. You will receive an email notification from our listserv. And finally, a certificate of attendance will be available for download at the end of today's presentations. Please note, the certificate is for personal portfolio use only, and we are not able to offer CEU credits for today's event. So we have American Sign Language interpretation for today, and we have two interpreters. You'll see them on the screen, alternating back and forth today, and their names are Pamela Mitchell and Megan Thorpe. And there is also live captioning for today's event. To view live captioning, click Live Transcript CC and then select Show Subtitles. And here's a quick look at today's agenda. And before we move into the presentations, it is my pleasure to introduce our three distinguished speakers. Dawn Peel is Director of the Office of Crisis Coordination at Georgia Department of Behavioral Health and Developmental Disabilities, that's DBHDD. She has been with DBHDD for 12 years and has worked in the behavioral health field for over 26 years in a variety of roles. She is a licensed professional counselor and a certified professional counselor supervisor. Previously, she served as the Behavioral Health Regional Services Director for the Region 2 Field Office. And in her current role, she is responsible for oversight of the DBHDD state-funded crisis system, which includes implementation of 988. Lori Cox is Director of Crisis Services at SWOPE Health Services, which is a federally qualified health center providing medical and mental health services throughout Greater Kansas City. She is an MSW and holds clinical licenses in both Missouri and Kansas. And she has been part of Missouri's crisis intervention system since the late 1990s. During her career, which spans almost 40 years, her primary focus has been crisis intervention and community mental health. Lori Cox, together with University Health's Behavioral Health Department, developed a 24/7 mobile crisis response team for individuals in Kansas City's urban core. And this is the first such collaboration in the state of Missouri. And Julie Phillips is Shared Services Program Director at the Mid-America Regional Council in Kansas City, Missouri. She is Project Director for a SAMHSA-funded Community Crisis Response Partnerships Grant, facilitating collaboration of mobile crisis response across 5 certified community behavioral health organizations, that's CCBHOs, in the Kansas City metropolitan region. Prior to moving to Kansas City, she led a coalition in Longmont, Colorado, focused on community mental health education and awareness, as well as chairing a Boulder County, Colorado collaboration focused on disaster preparedness, recovery, and resilience. And I'm just going to share some observations about who is in the audience today. Thank you all so much for responding. And I'm just going to get my glasses here. It looks like the majority of you today are calling from urban areas, almost 50%. About a third of you are from rural areas, and about 20% are calling from suburban areas. Today, of those who responded, nobody let us know that they are calling, joining from tribal lands. And we have a number of types of organizations included here in the audience today. It looks like the bigger groups are community-based providers and government and policy. We also have a number of you from law enforcement, public health, judiciary, hospital, corrections, academia, and a few of you who answered other. So thank you all for responding, and thank you all for joining us today, taking time out of your day to hear these presentations. And with that, I am going to turn this over to Dawn Peel to get us started. Thank you so much, Dawn Peel.
Thank you, Erica. Hello, everyone. Thank you for having me with you today. I'm going to take some time this afternoon and talk about some of the strategies that we've used in Georgia to develop and enhance our mobile crisis services. So the Georgia Crisis and Access Line is the sole call center for Georgia, and it also is our 90-day call center. All calls that come in are triaged, assessed, and a determination for the appropriate level of care is made. It should be noted that if an individual needs mobile crisis services in Georgia, they cannot access them outside of calling the Georgia Crisis and Access Line. So when someone calls, the clinicians on the phone figure out what next steps are needed after doing their assessments. In many cases, the individual can be de-escalated and referred to an outpatient service provider in the community. In other situations, the crisis cannot be de-escalated and the individual is referred to mobile crisis services. And then in still other circumstances, the individual cannot be de-escalated and they're referred to a community-based crisis center if that's what they prefer. So I just kind of want to go through the process of what happens when a person calls the crisis center, the call center, excuse me, because it really impacts what happens next and whether or not a mobile crisis dispatch is warranted. So as I said, a call comes in, the call center staff quickly and thoroughly assess the individual. They de-escalate them whenever it's possible, and then they make a determination of next steps. If an urgent response is required, they then also determine, is there an immediate danger present? If an immediate danger is present, they will do a warm transfer to the individual's local 911 call center for what we call an active rescue. And I'll talk a little bit more about that momentarily. But if the immediate danger is not present, they will refer the individual from mobile crisis team so that they can go out and do the assessment. So this slide has a lot of information. I recognize it's a lot to digest at once, but I'm going to hit some of the high points here. So when we talk about what an active rescue is, active rescues are defined as when an individual has an urgent need that needs very immediate response. So as you look across the table, you can recognize some of the types of things that pop up. imminent medical emergencies or imminent types of situations where an individual or someone else or property could be at risk of harm. Typically, the first responders that go out when an active rescue is warranted are law enforcement or emergency medical services. And then they go out and they do an assessment and either take the person to a medical facility if it's a medical emergency, or intervene in other ways if individuals are at imminent risk to themselves or others. In Georgia, like most states, we have a very strong CIT training group that's run through our Public Safety Training Center. And so typically when an active rescue is needed and law enforcement is involved, they will request a CIT trained officer to go out and assist. This is not on the slide, but I think it's important to know that in Georgia, the percentage of active rescues that result from calls coming into our Georgia Crisis Nexus line, whether it's through calling the 1-800 number or through 988, is about 1 to 2% on a monthly basis. So the vast majority of callers that reach out for help are being served in a non-law enforcement, non-EMS type of setting. And our 1 to 2% is very much in line with national metrics around this. So we feel like we're doing a good job there. When the call takers determine that a mobile crisis response is needed, there are many factors that go into that determination. So our providers use the LOCUS, the Level of Care Utilization System, or the CalLOCUS for children. But they also do a thorough yet brief clinical assessment of lethality and risk. We call these level of care assessments. They're not a full biopsychosocial, as you might imagine, that a person might receive if they're going in for an intake appointment, or even a more robust biopsychosocial if a person is going to a behavioral health crisis center. They have very specific questions that they ask to really determine what's going on with that individual in the moment, again, to determine next steps. One of the things that we work really closely with our call takers on and their leadership is to give the clinicians some flexibility. So if their clinical assessment makes them lean in one direction, but the LOCUS does not, they don't have to be necessarily hemmed in by what the LOCUS says. So if the LOCUS says the person's at moderate risk, but their clinical skills and their clinical judgment indicates a higher risk, they can certainly dispatch a higher risk or a higher level response, whether it's active rescue or the different types of responses that I'll talk about here momentarily. Oops. So again, this table has a lot of information in it about what types of presentations that the call takers might see result in a mobile crisis response. I do want to draw your attention to the left-hand column though, because there are several considerations that go into making a mobile crisis dispatch. So there's an assumption or confidence that the individual can be kept safe for up to an hour. The reason that we have that in place is that our mobile crisis providers have a contractual expectation to arrive on site within an hour or less. So if the call taker does not feel that the mobile crisis team can get there fast enough, that's when they will transfer them to 911 for an active rescue. Our mobile crisis services are also voluntary. So the individual needs to be willing to participate in the assessment. If a third party is present, if collateral sources are present, they can also provide information, which is often very helpful for the mobile crisis team. And then if the individual was previously agreed to services through mobile crisis, but wasn't present when the mobile team showed up or later called to cancel the mobile dispatch, then they can use that as a criteria for dispatch as well. So as you can see from the different types of criteria related to symptoms, they're somewhat at a lower level than you would see for an active rescue that we just looked at. So if a person has suicidal thoughts, um, but there's supports in place to keep them safe, a mobile crisis team would be dispatched. If they're experiencing symptoms of extreme depression, like helplessness, hopelessness, symptoms of severe psychosis or mania, but again, there's confidence that that person will be safe until a mobile team can be there. These are situations where we might have a mobile team dispatched. One thing I want to draw your attention to is the column that relates to substance use disorders. Our mobile teams are not dispatched solely for service for people that are only having a substance use emergency. Typically, if that's the case, we have active rescue involved because of some of the different types of things that can happen, seizures, and other types of active withdrawal symptoms that can occur. But if the person is experiencing a substance use crisis and there is a related mental health condition, related intellectual developmental disability, or the person has autism spectrum disorder, then they can dispatch a mobile team. The corresponding locus scores for a mobile crisis dispatch are at a lower level. So as you could see from the active rescue slide, those are at very high levels or high degree of impairment, whereas these are more in the moderate range for our mobile crisis. So I'm going to take a few minutes and talk about the different levels of mobile crisis dispatch. So once it's been determined that a mobile crisis team is appropriate, the call center can make a determination of which is the most appropriate response. One thing I'll say is if the call center identifies, for example, it's a level 1 dispatch or a level 4 dispatch for a mobile team, and the mobile team decides that whether the person's situation is escalated or something else has happened and they need to escalate it to a higher level, there is that flexibility in the system to do that. So it's not set in stone when the dispatch referral is made. So level 1 is our highest level of dispatch. And this level is initiated when the individual is very likely for intent for a suicide attempt or a homicide attempt. And in this situation, law enforcement is dispatched along with a mobile team. And law enforcement is asked to lead in that situation. So going in, making sure the individual is safe and the setting is safe for the mobile crisis teams. The mobile teams are instructed to heed the instructions of police because if the individual or the setting is not safe, we don't want our mobile teams going in against the advice of law enforcement and potentially making the situation more dangerous. Level 2 dispatches include a mobile crisis team with law enforcement in the background or maybe around the corner, but not on scene. And these levels are dispatched when there's a history of aggression, recent acts of aggression, or recent acts of self-injury. In these settings, our mobile teams go in first, but have law enforcement right there if needed for assistance. Our level 3 dispatches are where our mobile teams lead, but law enforcement might be on standby by phone if they're needed. And again, there's a lot of clinical judgment that goes into this, and there are the option to escalate it up or de-escalate the level down, depending on the needs of the individual. Level 4 assessments are when mobile crisis teams go out all by themselves, do the intervention, and law enforcement is not even notified or involved. And then we have level 5 assessments that occur in a secure location, such as a hospital emergency room, a jail, a youth detention facility, or other types of places like that. And in those situations, the mobile teams can do in-person response, but they can also use telemedicine if it's appropriate for the individual and the staff and individual agree. Um, the slide does say that they can do a one-person response, but we still do encourage two-person responses for those safe settings because of the benefits of the two-person teams. So as I just mentioned, our mobile teams are comprised of a first responder and a second responder. The first responders are typically independently licensed clinicians, whether that's an LCSW, a licensed professional counselor, a licensed marriage and family therapist, or for individuals that have intellectual developmental disabilities or autism spectrum disorder, it could be a board certified behavior analyst or an associate BCBA. And then the second responder is typically a paraprofessional or a certified peer specialist. So we think it's really important to have two-person models for a number of reasons. The pros of that is, first of all, safety. We want our teams to be safe in the community. They go into some really potentially dangerous situations at times, and situations that can escalate very quickly, depending on what's happening on scene. And so, you know, the old adage, safety in numbers, is something that we think is really important for our mobile teams. The other thing that we've seen with our two-person teams is that the assessments are much more efficient. So the clinician can be doing the assessment, the locus, on scene, and the paraprofessional or the peer can be talking to other people on scene, whether it's family or if it's a group home, staff or people like that. What we also know is that our certified peer specialists are absolute experts in de-escalating. And so while the clinician's doing an assessment, the peer might be able to work with the individual and de-escalate them so that they're not having to go to a higher level of care. The downsides of two-person teams is that sometimes it takes them longer to get there. So if you've got one team member that's 15 minutes away and the second team member that's 45 minutes away, it might decrease or increase the response time slightly because they need to meet up before they can go on scene together. And then, of course, the staffing shortages that we have experienced has had a greater impact because the closest person might be further away than if we were fully staffed. So I want to address unsafe situations because it's a very real concern for our teams, for their leaders, and for us at TBHUD that contract for these services. So as I said earlier, our teams can go virtually anywhere in the community. The majority of the calls are responded to in a person's home. So there can obviously be challenges in a person's home that can come up at a moment's notice sometimes. Our mobile teams and our call center teams do a really good job of asking the right questions to make sure that the setting is safe, but sometimes people don't tell the full story when they're calling in, or sometimes the situation can escalate, as I said earlier. We've worked with our providers over the years. We've had mobile crisis services for many years statewide, and we've worked with them to continually identify ways to maximize safety for the staff, but also for the individuals that we serve. As I noted earlier, mobile teams can always reach out to law enforcement if possible, and we work with them very closely to build and nurture the relationships with law enforcement so that law enforcement knows they're only being called when it's absolutely necessary. And then a new feature that's come up with one of our mobile crisis vendors is that there is a phone app that all of their mobile teams use that tracks their GPS location, but also has embedded safety check-ins that if they're not using the app to upload information about the assessment or things like that, it will ping the team members to check on their safety. Another important feature of the mobile app is that it allows for a silent 911 call. So imagine if you're in a situation, maybe in somebody's home, maybe on a street corner or somewhere else, and it's quickly escalating. You may not want to get on the phone and call 911 because that just might further escalate the situation. And so they can, this app enables them to reach out to 911 silently. I did want to share a metric that we have for our mobile crisis teams as it relates to law enforcement involvement. And so I didn't put the percentage up there, but it is less than 5% of all of the mobile crisis dispatches in fiscal year 23 that needed a law enforcement involvement. So that's that levels 1, 2, and 3. We think that this metric is really important to share with lots of different people. We like to share this when we go talk to the Sheriff's Association and other law enforcement partners, because some of the feedback that we get is they feel like they're always being called when a mobile team is going out, and we can share this data and say the vast majority of their calls, you never even know that they're happening in your community. And that really helps to build partnerships and help them to understand the importance of these teams. So I quickly want to talk about telemedicine, and then I'm going to play a quick video before I turn it over to my colleagues from Kansas. So during the pandemic, telemedicine was brought in for our mobile crisis teams out of sheer necessity. Our teams were still willing to go out and were really inventive about how to do an assessment safely in person. But there were a lot of people that didn't feel comfortable having people to come to their homes, and emergency rooms and jails were not allowing outside staff in to do mobile crisis assessments. And so we got creative. We worked with our providers and we put some protocols in place. Well, as the pandemic winded down and we had to unwind all the public health emergency protocols, we worked closely with our mobile crisis providers to determine what do we need to keep in place for telemedicine. And in working in conjunction, we determined that telemedicine is appropriate in a safe setting. So those level 5 assessments that I just talked about, they're appropriate when a person is able to participate in the telemedicine assessment. So if an individual is floridly psychotic or has a developmental disability that renders them unable to participate via telemedicine, then a face-to-face assessment, it will still be done. Of course, they have to have the proper technology and broadband access to facilitate a telemedicine assessment, and they have to be willing to be assessed via telemedicine. We made it very clear that telemedicine should not be a convenience for the mobile crisis providers, and it should be a tool in their tool belt that can be used to make it more accessible and faster for the individuals, but not at the expense of those other things that we talked about, that it's by choice and have the proper technology in place. So I am going to turn it over to our facilitators to start the video, and after that, I will turn it over to our colleagues from Kansas. Thanks, y'all.
When a person who has called or texted 988 needs someone to respond, a trained mental health professional at the Georgia Crisis and Access Line, also known as GCAL, might dispatch a mobile crisis response team to help de-escalate the crisis and assess the individual for the right level of care. Once they get the call, the mobile crisis team will reach out to the individual or the person who called on behalf of the individual in crisis. The team will first confirm the information they received and will provide an estimated time of arrival. Usually, mobile crisis teams respond to people in crisis face-to-face by traveling to their location, but they can also meet with the individual using telemedicine when the person is in a safe setting, like a hospital, jail, or school, and when others are around who can keep them safe, share information, and help the person communicate if needed. Mobile crisis teams that respond on site are comprised of 2 team members who work in concert to meet the person's immediate needs. Teams are comprised of a master's level or licensed clinician and a paraprofessional or certified peer specialist. Before they respond, mobile crisis team members receive extensive training on rapid assessment, crisis intervention, de-escalation, and how to provide person-centered and recovery-focused services. There are 2 members on each team, which ensures the safety of responders in a crisis, and it allows the team members to talk with multiple people and/or conduct an assessment and de-escalate the person at the same time. Because it's important to respect the privacy of people receiving mobile crisis services and avoid further escalation, the crisis teams arrive dressed in plain clothes and in unmarked cars without lights and sirens. As a result, it usually takes them longer to respond than a first responder who is dispatched through 911. The expectation is for mobile crisis teams to respond on site within 59 minutes. Once the team arrives on scene, mobile crisis responders immediately get into information gathering mode. They talk to the individual in crisis, as well as other people such as family members, teachers, or others who are present and who are willing to share information. These details, along with the clinician's observations, are critical in making an assessment and recommending the next steps based on the person's needs and preferences. In most cases, the crisis can be de-escalated and is referred to an outpatient appointment. Other situations might require further evaluation and treatment to ensure someone's safety and the safety of those around them. When a responder determines an individual in crisis needs further evaluation, team members will work with the person to seek treatment voluntarily because evidence shows people have better treatment outcomes when they choose to seek help on their own. Licensed clinicians only sign a 1013 or 2013 order that requires the individual be transported to an emergency receiving facility for evaluation when the person is determined to be at imminent risk to themselves or others and will not voluntarily seek evaluation or treatment. Mobile crisis teams work hard to identify the least restrictive level of follow-up care that meets the person's needs based on their current wishes. Mobile crisis services are available statewide in Georgia and can respond 24 hours a day, 7 days a week, and 365 days of the year. They serve people almost anywhere in the community. This service is funded through DBHDD and is available to anyone in Georgia, regardless of insurance status.
All right, I'll turn it over to my colleagues from Kansas. Thank you.
Thank you, Dawn. Good afternoon. We are so pleased to have the opportunity to share with you today on behalf of our collaborative. Today, our focus is going to be on sharing about the collaborative approach that our region is taking to mobile crisis response. Oh, sorry. So I wanted to start by just giving you a little bit of an introduction to our region. We're located in Kansas City, Missouri, right on the state line between Missouri and Kansas, and our mobile crisis response collaborative is focused on 4 counties in Missouri: Clay, Platte, Ray, and Jackson counties. They all make up part of the Kansas City metro area and also represent urban, suburban, and rural communities. Within that 4-county region, we have a combined population of just over 1 million people. We have 22 public safety answering points, so 911 dispatch centers, 62 law enforcement agencies, 58 fire districts, and 37 EMS districts. And we have 5 certified community behavioral health clinics, or CCBHCs, providing crisis services, including mobile crisis response. What is unique about our approach is that we are approaching it as a collaborative. So as I said, we have 5 CCBHCs in this region that we are working with and working together. In addition, we have a separate organization, ComCare, that answers all the 988 calls for our area. ComCare was formed back in the mid-90s in response to managed care, and all of the CEOs of our CCBHCs are on the ComCare board. So that means that our CCBHCs not only have a strong relationship with ComCare, but they provide guidance and oversight to the organization.
And then Mid-America Regional Council, or MARC, as we call ourselves, is a council of governments. And so we're a regional coordinating body that seeks to provide cooperative planning and coordination across jurisdictional lines on issues of mutual concern in our community. And so we're serving as the convener of this collaborative. We led this group through a strategic planning process in 2022 to help identify the ideal delivery system for mobile crisis response in our community, all in preparation for the rollout of 988 and the statewide requirement in Missouri for 24/7 mobile crisis response. Just over a year ago, our group was awarded a community crisis response partnership grant from SAMHSA, allowing us to formalize this collaborative and begin implementation of that strategic plan. Our goal has been to ensure that mobile crisis response is delivered in a consistent way by all 5 CCBHCs so that no matter where you live in this 4-county region, individuals can expect a consistent quality of mobile crisis response and post-crisis follow-up. We are just a couple of months into year 2 of our 4-year grant and are focused on 4 key areas. Of course, delivering mobile crisis response services, but as a part of that, identifying opportunities to share services in areas of training and staffing, working on shared protocols, ensuring alignment of service delivery across all of our agencies. We are working on building partnerships across the community, particularly right now with our law enforcement and first responder partners. And we are focused on educating the community about 988 and mobile crisis response, all with the goal of seeing both, seeing an increased utilization of both in our community.
Okay, the grant has been an excellent opportunity for these 5 CCBHCs to pull together and be able to align our services across the region, particularly those of us that are within Jackson County. Folks move around a lot. And so we want to make sure that they get the same service wherever they happen to land should they need mobile crisis services. All 5 of the CBHCs do get dispatched from ComCare, the crisis line, and ComCare receives the 988 and our regional crisis calls, and they follow a similar process that Dawn explained regarding determining when to pass it on down to a mobile team. Our mobile teams do provide 24/7 coverage. It may vary in how the centers provide that, but again, it is available in every service area in our region. We also have a minimum of 2-person teams. The team will consist of a master's level clinician, a bachelor's level clinician, and we are working toward every team also including a peer specialist. Some of the centers are able to do that at this point, but we haven't yet got that totally across the board. We also have an emphasis on minimizing our law enforcement involvement and utilizing the hospitals and particularly the EDs. And the other thing that we have been able to better align is offering transportation to individuals if moving them to another location is beneficial in resolving the crisis, whether that be to an urgent care, crisis center, another family member's home, wherever that might be. In the past, that's been quite a struggle. We all have the ability to transport individuals ourselves without having to use law enforcement or EMS. And we can also use like Uber and those kinds of things as well. And here's some of our numbers for year to date since January through September 2023. The number of individuals screened for suicidal ideation, this includes all the calls that hit ComCare from the 988 and from the regional crisis line, but it also includes those individuals that walk into our community mental health centers. And then again, we have the process for filtering them down to determine whether or not they need the mobile response. 96% of our responses have been in less than an hour, with an hour being our target. So 27 minutes is our average, which is better than the current state average. So we're quite proud of that accomplishment. And 75% were resolved in the community, which means they did not require a more restrictive level of care. Here are the primary problems that individuals contact us about. You'll see that a majority of those are acute mental health crisis, which could involve a suicidal ideation, but it's frequently psychosis, but it's anything that puts them in a position where they need someone to respond right away. They can't wait for that appointment the next business day or whatever. Mental health needs referral assistance, and then currently suicidal. We also have this other category, and that obviously is where nothing else fits, but that's also where we record folks that are doing the self-harm without the suicidal intent. Location of response, you see that facility and home are two primary. Again, the facility being those that are walking in to our community mental health centers is where that we are catching a large number of those. Transporters, you'll see the majority of the transports have been by our mobile crisis teams. And transporting to, want to note that none are transported to jail or prison. So again, another high achievement for us. And treatment facility, a lot of that is outpatient services. It's not all inpatient.
So in the first year of our work, we've really been focused on building the infrastructure and really building just how we can collaborate and share services across agencies. And one of the ways has been around data. We've identified data that all 5 of our CCBHCs are collecting and reporting out to us quarterly. We have a project evaluator that compiles that data so that we can share that out with our community and with our funders. She's worked with them on developing shared definitions. I mean, part of what's been really unique about our collaborative is that there is not a shared database or record system across all of these agencies. So there is, in order to monitor and report on our KPIs, we first had to work through those definitions and ensure a standard interpretation across the 5 CCBHCs and ComCare in order to have accurate aggregation of our data and of our measurable goals. We're also working on shared protocols and practices, and in a moment, I'm going to give you an example of one of those, and really developing those partnerships and doing so, again, with that collaborative approach. An example is with our largest police department in the region, Kansas City Police Department. All 5 of our CCBHCs, their catchments overlap with the service area of KC Police Department. And so rather than, they all have individual working relationships with them. They all have community behavioral health liaisons. But at the same time, we wanted to take a cooperative approach to working with them, inviting them to our steering committee meetings, having conversations about how we can work consistently across all agencies with them. And we know that has really been a benefit to them as well. And is something we're looking to do with other partnerships. And then finally, really having a shared approach to our community outreach strategies. So as I shared, one of the things that we are working on and is essential in collaborative work is shared processes and protocols for what we're doing. And so this is where we're so grateful for the partnerships and the cooperation across all the agencies. ComCare developed a crisis call workflow for their 988 call takers. Much like Dawn talked about as well, like just the process of when a call comes in, what is the response? And so when we got to the point about mobile crisis response, they brought the workflow to our team. And as a group, they went through line by line to reach a consensus on when will a mobile team dispatch across all of the regions. And so, that is of great benefit, not only to our community members, but also to the 988 call takers to say, okay, we know that any call that comes in this region, there's the same criteria. We don't have to go and say, well, they're at this center, so, they will take a mobile, oh, this one won't. It is consistent. And so that is something that we've been working on and developed, and we continue to develop additional protocols with our team. I'm going to let Lori talk a little bit more about this protocol in particular.
Yeah, and I'll have to say that working on this workflow was not as painful as some of us thought it might be when it was first presented as an option. It was actually very amazing for all of us to be in the same room with ComCare and walking through and discussing this and sharing opinions and being able to work through that. And I think one of the things that enabled us to do that is that not only have we all worked with ComCare for quite some time because they provided our regional crisis services, but we've all worked together on various projects with the Department of Mental Health. So those relationships had been established, and that helped us to really be able to address these things. Some of the things that came out of this that brought around, again, some changes in our region is that we decided to have a no wrong door approach. With the way that our service areas bump up against each other, it can be hard sometimes to determine which service area is someone actually in. And we have historically had different opinions about that at times. And so we didn't want it to be where ComCare would look and they would say, okay, so this belongs to this agency. They call that agency and the agency goes, oh no, that's not my service area. It needs to go too. We decided that whoever ComCare calls, we will handle the situation and then we can work it out the next day or whatever as far as getting that addressed. However, that conversation identified the fact that we were all looking up service areas in a different way, which was not helpful. And so Mark was able to create a web-based service area map that all of us are now using. And so we all have the same source of information when it comes to figuring out, which mental health center is truly closest to this individual. And then the other thing that we discussed and kind of reworked as a part of this process was third-party callers. In the past, we would talk with them on the phone and assist as we could that way, but we would not go on site. And so the group made the decision that why not go on site? Let's go on site. Let's talk with the caller. And if the caller can engage us with the individual, wonderful. We can then try to assess the situation that way. But if not, we can always assist that third-party caller in how they can best work with the individual and resolve or at least somehow manage whatever is going on at that point. So it was pretty exciting, some of the things that came out of just that one process. And then the other thing that I want to talk about is the shared service model that we have created with University Health. This has been such an exciting experience. And it's the only one that's being done in Missouri at this point. And truthfully, how this kind of came out is that when I was tasked with creating a 24/7 mobile crisis response team, I was like, oh, whoa, this is huge, because we were already having staffing issues in other areas. And it's like, how in the world is this going to happen? So in talking to my managers, it was like, let's start talking to the other CMHCs and let's see if anyone else wants to partner. And University Health was in agreement to try this out. Let's see how it works. And so our CEOs worked together to get all of that legal stuff gone and in place so that we could move forward. We've met weekly for over a year now, just discussing different things, making sure we're on the right page. Of course, we had to do policies and procedures and all that wonderful stuff. But it has not been without its challenges. The legal departments have been interesting on both sides. Trying to get an MOU reviewed and approved by both has been a little bit challenging. We worked through that. Our financial departments, mine was quite puzzled when I would route invoices through that said half of this has already been paid by University Health. We need to pay the other half. And they're like, who does that? They just really struggled with that. IT was also another adventure because one of the things that we chose to provide was cell phones to all of the mobile staff. University Health uses pagers and not cell phones, but we wanted all of our mobile team to have cell phone access. So we created that option through Swope. And our IT still asks me anytime I request one that's not for a Swope associate, they're like, and we're doing this how and why? So still working through some of those things. It has been a great help on the staffing side, but there are still some challenges in that ultimately our desire is that every team that goes out, one person will be University Health and at least one person will be Swope, so that we have at least representation from both organizations to go out. And we still struggle to meet that actual 50-50. But it's coming together nicely, and we've been very excited with how that has come along. I think one of the things that I most enjoyed about that was being able to come to the table, and the transparency, the willingness to talk about here's where we struggle, and here's what our strengths are, and to be able to balance those and make those things work for the betterment of this particular program has been pretty awesome. Because as most of you probably know, organizations can have some turf issues, and there's things that we don't want other people to know about. But when you're working in this kind of a collaboration, you have to be open and honest about those things so that you can work through and make the things happen that need to happen. And then this combined logo was also another exciting thing that we were able to create. Our teams have shirts with and jackets with that on it. They have backpacks. Our vehicle has got it on the side. And so we wanted the community to know who we were, and not to necessarily know that we're there for mental health reasons. So some of the benefits that have come out of this collaboration, and which we hope eventually we will be able to spread that out across the entire region as we collaborate more in some of these areas. The individual benefits, non-clinical setting, seeing them where they are, diverting the 911, the law enforcement, because as you all know, they're already stretched beyond and short-staffed. So, and this is not the appropriate thing for them to manage. Even though we have a very strong CIT program and those guys are amazing, law enforcement is not necessarily the best thing to show up for these. And avoid some unnecessary expenses for the individuals, particularly when it comes to transportation. Our agency benefits between the two of us is pooling the staffing and sharing that load, as well as doing the combined training. And we've also done a regional training involving all groups, all of CMHCs. Sharing the resources. One of the challenges that I have is that we don't have office space. University Health does. So we house our full-time people over there at University Health. We were able to purchase a vehicle. So that vehicle will also be stationed over there at University Health, where everyone has access to it. They have a hospital location, so there's a little bit more flexibility with that kind of thing. And then, as I mentioned earlier, the combined expertise and strengths that we both bring to the table. The community benefits, I mentioned earlier, the standard of care and the same expectations across the board. And then, as Julie discussed, this relationship management, we're not all going to the same organizations that we all work with, asking for the same thing or different things. There's more of a coordinated effort with that.
The other thing I was just going to add in terms of just learnings and opportunities from the larger collaborative is just the opportunity for all of our mobile crisis teams to learn from one another. Our group meets together monthly. We have a steering committee that is made up of the crisis staff, the crisis directors, and from each of our 5 CMHCs, as well as the staff for ComCare. And so one of the things that we are beginning to do and building into just our gatherings is opportunities for each team to share about some of their mobile responses. maybe questions that have come up or challenges, sharing just success stories, but having that as a place to learn from one another. And we're also working towards bringing all of the mobile crisis responders from all of the agencies together. Again, not only for shared training, but just for learning from one another and building that sense of community and cooperation across agencies. As you can see, that the theme of building partnerships is a critical part of the work that we've been doing. We've spoken a little bit about what we've been doing with law enforcement and wanted to share just a little bit more about that. It's a big focus for us as we head into the second year of our work and are really excited to explore the possibility of diverting calls from 911 to 988, allowing mobile crisis teams to respond when appropriate. And so we're approaching that in a couple of different ways. First, I will say that we're very fortunate to have a strong CIT program in the Kansas City metro region. It began in the 90s, and that relationship is the result of years of relationship building across our agencies. In addition, 5 of our law enforcement partners in Eastern Jackson County have been operating a co-responder program for over 3 years now with 2 of our CCBHCs. So those relationships are there. And as we have begun to approach partners about 911 call diversion, there is a lot of interest and willingness to have those conversations with us. And we're very excited about that. We have been able to use our team to help do some research around best practices across the country, looking at models for 911 call diversion, embedding 988 call takers in 911 dispatch, just getting ideas of what's happening across the country and what we can do in our Kansas City region. And we've been able to set up some virtual conversations. We're planning a couple of site visits. And in addition, just really trying to bring our law enforcement partners into the fold of the work that we're doing. And so we've done that in a couple of ways. We have started hosting regular informational sessions, inviting our law enforcement and first responder partners to come learn about 988, about mobile crisis, if they aren't already familiar with that, making sure that they understand that those are resources available to them as well when they are out in the field responding, helping them understand a little bit about our collaborative and how we work together, and then inviting them to get more involved. I shared before, but I will say again, part of why this is imperative for us is because we have a lot of relationships to build. We have 62 law enforcement agencies, 58 fire districts, and 37 EMS districts in the 4-county region we're working in. So there's lots of opportunity there. And once our next step in this process has been to form a group that really wants to talk about what implementation looks like for 911 call diversion programs and practices. So we now host monthly meetings, bringing our partners together. Right now, it's really just hearing about different models, having folks talk about what they might want to pilot in their agencies. And eventually, as we move towards implementation of some of these programs, a place for our law enforcement and first responder partners to meet with us and to talk about what's working, what are they learning, so we can continue to learn from one another and continue to grow this program in our community. And then finally, the last kind of focus for us and something that we have found to be really important is just how critical it is for the community to understand what 988 is and mobile crisis response. The national data tells us that there's still a significant portion of the population that doesn't know either what 988 is or what happens when you call. And we've heard that just anecdotally from people in our community. We know that a lot of folks in the community don't know that mobile crisis response is available to them. And so again, harnessing the power of cooperation and collaboration, we have developed our first marketing piece that is co-branded across all of our agencies just trying to provide some quick summary points about what 988 is, what to expect when somebody calls, what a mobile crisis response is. We have developed a shared PowerPoint presentation drawing upon the materials and the toolkit that SAMHSA provides with all that information, also wanting to make sure that there's a consistent message, as we know that there are statewide and national efforts around marketing, wanting to make sure that we stay in alignment with all of that. But we have developed a shared presentation so that we can go out in the community and do that together. We all have, limited capacity to do that. None of our teams have, extensive staff to just go out and do these types of presentations. So being able to team up together, have a shared calendar and strategy for how we can go about education and outreach efforts, and then using the data that we're collecting to identify groups in the community that are not high utilizers of mobile crisis response, that are not high utilizers of 988, and making sure that all individuals in our community know that these are resources that are available to them. And ultimately moving towards developing a train the trainer type model, so that we can train others and they can go out on our behalf to continue those educational efforts. And so that's the end of our presentation. As you can see, this collaboration has been such an exciting thing for us to be a part of. And I just have to say, Lori and I are part of a team of amazing people that are doing this work. And we're really honored that we could represent them during this time. If I had my way, we would have brought the whole team. So just know that we represent a whole team behind us that is doing this work in Kansas City.
Great, thank you so much. And I would like to just take a moment to say thank you to all three of the speakers today, and really to applaud them for the critical work that each of you are doing in your communities. So thank you for sharing your knowledge and your collective experience with us today. We have, as promised, some minutes left at the end of today to hear questions from the audience. And so we're going to get started with that right now. If you're in the audience and you haven't typed your question for the speakers yet, please head over to the Q&A, which is at the bottom of your screen, and we will cover as many questions as we can in the time remaining. So the first question is for Dawn, and there were a number of people who asked, so I'm just going to kick off with that. And this is, Dawn, are you able to share any additional information about the app that you talked about? For example, is it available to anyone? And if so, where can it be found?
Yes, thank you. I hope you can hear me. I had to switch to audio. My microphone went out after I spoke. Before I answer, I want to apologize to my colleagues from Missouri, because I kept saying that you were from Kansas. I know it's right across the line, but I do actually know geography. So I apologize for getting that wrong several times. To the question, though, so one of our mobile crisis providers is Behavioral Health Link, and they have the app. It's a proprietary app that they use. If you'd like, I can drop the contact information for their CEO in the chat if you're interested in learning more about it. It's pretty new for us, so I don't have a lot of other knowledge about it. I have the basics, right? But we've not been working with it for an extended period of time. So I'll answer questions as best as I can, but I may have to defer some of them to our colleagues at BHL.
Thank you, Dawn. Okay, let's start this next question with Lori and Julie. And Dawn, if you want to chime in also, we'll kick it over to you. So we have an audience member asking, what are some recommendations for finding out what the procedures for mobile crisis teams are in their local county? This particular audience member is in Florida. So if you want to speak to that area specifically, if you know, if not, maybe just some general tips about for this person who's asking the question.
I would suggest, and I know nothing about Florida, but if you are familiar with the community mental health centers in the area that might be providing this service, you could certainly reach out to one of them. But I would imagine that you could get some direction from the 988 call center. So whichever call center is handling the calls where you are, they should be able to either give you that information or direct you to the appropriate people to talk to.
Thank you. And Dawn, any other tips or suggestions that you would like to add before we move on?
I think that's probably great advice. I mean, I don't know the state entity in Florida. I know that there is one. They might also have information, but I think the community mental health centers are probably the most direct route to go.
Thanks so much. And Dawn, this question also was directed towards your presentation. Are all the teams coordinated across the state under one umbrella organization, or are they locally run?
So they're coordinated under DBHCD. So the state of Georgia contracts with two different mobile crisis providers that provide statewide services. The state of Georgia under DBHCD is broken up into 6 geographic regions. And so we have 6 different teams or groups of teams. Behavioral Health Link is the provider for 4 of our DBHCD regions, and Benchmark Human Services serves the other 2 regions. But there's a great deal of coordination because the fact that the state is, you know, we write the contracts, we write the service definition, it's in our provider manual. So I hope that answers your question. If not, I can take another stab at it.
Thank you, Dawn. Okay, and I'm going to open this up to whoever would like to offer information. This is about shifts, staffing and shifts. What shifts do you offer? Meaning, what model of coverage do you find most successful? I've heard of 12-hour shifts, 8 hours, 48 hours with 5 days off, etc. Whoever would like to take a stab.
I can jump in. I don't know which ones are preferable. We have a provider that does your typical, 8-hour shift, 40 hours a week. We've also had providers in the past that, have done more like the 48 hours or on and like week on, week off type thing, or time on, time off things. In Georgia, we don't get that specific with our providers about what types of shifts they should use. But one of the things I can say is that working with our providers, the group that did the kind of on-off type thing where it was some time on and then a block of time off, found it easier to get people that had another job, say they had a private practice, and they would do this kind of to supplement that. So that's kind of the input I have. Lori, Julie, I don't know if you have other thoughts from Kansas City.
Yeah, the only thing that I would add is that we have full-time staff that fill our 7A to 3P and our 3P to 11P. And then we fill in everything else with PRN on call folks. And so generally it's an 11P to 7A Monday through Friday. But on the weekends, we'll either split it into those 3 shifts or fill it however folks are available to fill it.
Thank you. And this question is around staff training. So let's start with, actually, I think anybody, let's start with Julie and Lori, because I think the question came up when the 2 of you were presenting. Crisis, you talked a little bit about crisis call workflow, and this audience member is asking, what is the training for call takers? Can you share any recommendations for developing training for call takers?
And we don't have call takers. That's all done by ComCare. So I'm not real familiar with what their training is at this point.
Yeah, I was going to say we could find out and share back out to the group, but I would say asking Dawn, since that's, she's working with their 988 call center there.
Sure. So we require specific types of training or topic areas for training. And then our providers are contracted to provide that training for their staff. So it's everything from, like a locus risk assessment to de-escalation. There's also training on, person-centered care, trauma-informed approaches, and other types of safety things. I can see if I can pull up the list. I'll see if I can find the document with the list, and I can put it in the chat if I can grab it quickly.
Thank you, Dawn. And here's another question about ComCare. Kind of speaking to developing partnerships and collaboration, did ComCare already have its own teams and board before the collaboration? And if so, what was the reaction to adding heads of all the CCBHCs to the board? If you can answer.
I don't see Lori, or maybe she's just, because Lori's the one who can answer that for our group, because she used to be involved with ComCare. So I would want her to be the one to jump in.
Sure, and we can circle back.
Yeah, let's circle back to that if we can.
Absolutely, thank you. Okay, a lot of questions about transportation, and I noticed some conversations in the chat about this. One attendee is asking, can you describe the type and design of vehicles used for the transportation of individuals? For example, what types of vehicles are used? Are there barriers in the vehicles between the front seat and the passenger area, etc.? For anyone who would like to.
Yeah, this is Lori. Sorry, I had to switch to my cell phone because I had trouble with my computer. Yeah, we don't have any dividers currently and have not seen a need to do that at this point. We just have a typical SUV van in essence. We do have protocols in place for our staff to follow as far as when it's safe to transport and when it's not. There must always be the two of them in there, one sitting in the back with the individual, that type of thing. But we did not put dividers in our vehicles.
Thank you, Lori. And just in the moment where you had dropped off, there was a question about ComCare specifically and building collaborations and partnerships. The question was, did ComCare already have its own teams and board before the collaboration? And if so, what was the reaction to adding the heads of all the CCBHCs to the board?
Oh, okay. So no, actually ComCare was formed by our CEOs, by our community mental health centers. So it was not in existence until we created it. Is that the question?
Yes, I think that clarifies. Thank you.
Okay. Yeah.
Thank you very much. Okay. So this is for, let's see. Okay. So here's a question. For whoever would like to respond, have you had any significant safety events or injuries occur to your staff while responding to calls? And if so, have these experiences changed the way you respond to mobile team calls?
I'll jump in first. I'm not aware of any significant safety events or injuries. I do know that there have been times over the years where the mobile team felt that they were dispatched, say, for example, like at a level 4 with no law enforcement, and there should have been law enforcement dispatched. And so as a result, we were very intentional in making sure the teams know that, if they ever need assistance from law enforcement, they don't have to call and get permission from the call center. They should just act on that themselves. And then the other thing that we do if situations like that pop up is we get the specific information about what happened so that the call taker can be, if there's a training need, if there's, a systemic protocol type need that we need to address, then we can look at that. But I'll see if my colleagues have any thoughts about that as well.
Yeah, and we have not, thank goodness, had any incidents. However, there was a very significant incident in the Kansas City area, actually on the Kansas side, a number of years ago, which has heightened everyone's awareness and also it created obviously some anxiety because it was a case manager with a client incident. And so what we decided to do was invite law enforcement in to do some scene safety training and to help us to walk through some of those things just to heighten everyone's awareness. And we do repeated trainings with them in that regard.
Thank you. Okay, here's a question about third-party callers. So what are tips for managing these calls if the caller is not willing to stand by or is not on the scene to provide essential safety information?
If the third-party caller is not there, we won't go. We will respond to that third-party caller if the individual, because generally when they call us, it's because the individual won't call us and many times does not want us to come out at all. And so if that's the case, then that third-party caller is going to need to be present. So on the scene to either introduce us or however that may work. The most recent incident that we had, it was an adult son calling about his mother who was in the home, and it sounds like there was some psychosis and that kind of thing. And she was there, as was the son, introduced us, but she would not engage, said she was fine, didn't need to talk to us. And so at that point, our only option is to work with the son to see how we could assist him.
Yeah, and I don't have anything else to add. I agree with what Lori said.
Thank you both. Okay, this is a question for the Kansas City team. Just a clarification regarding screening protocols. Does Kansas City currently only screen for suicide?
No, we do a full risk assessment. So yeah, it would be your typical screening for safety in all regards, just to get a handle on what's going on before we go out. But obviously when we go out, we also do a full screening on the entire situation and what's going on with the individual and the environment.
Thank you. Okay, we've just got a couple more questions. We're going to try to cover them before we end. I believe this question must have been for the Kansas City team. Which communities or states have you already started moving into?
I don't know if is that, you mean, maybe that's just reaching out where we're doing some research on best practices.
I'm going to ask if that a participant is still on the call, if you could just type some clarification to that question and we'll try to get to you before we sign off. And okay, here we go. I believe this is also for Kansas City. What is the time frame measured for no suicide deaths following MCR response, mobile crisis team response?
The same time frame that is on the slide. I believe that's January through September of this year.
Thank you. And just a reminder to all the audience, we will be sharing the slides with all registrants following this event. So you will receive that information via the Gaines listserv. Okay, and this is, I'm actually not sure which speaker this was intended for. What percentage of calls result in hospitalization? Maybe if both teams could respond.
I don't have that data available. I could, if you want to reach out to me directly, I'll put my email in the chat, and I'm sure I could pull it up, but I just don't have it fairly accessible.
I was going to say, I think that's true for us as well. We have that data, but I just don't have it in front of me. But yeah, folks are welcome to reach out.
Thank you for that. And here's oh, here we go. Any recommendation for assessments or screening tools for children and adolescents within the school setting?
So in Georgia, there are mobile crisis teams use the CalLocus, whether it's a child at the house or in a school setting, in addition to the clinical interview the clinical assessment that they're doing.
Thank you. All right, and I think we are just about out of time, and we have a couple of wrap-up slides that we do need to cover. So we are going to start moving into the wrap-up now. Once again, want to thank all of our speakers, Dawn Peel, Julie Phillips, Lori Cox, and we have a certificate of attendance for anybody in the audience who would like to download that today. We're going to put it in the chat. And so we'll just take a moment to let folks do that. And next slide, please. So just to let folks know, if you're subscribed to the Gaines listserv, you will receive a notification about this upcoming event. We do have another webinar coming up on December 19th. It's exploring technology solutions for criminal justice, substance use treatment, and mental health agency partnerships, and we hope you can join us. And we do have a closing poll here. If you would like to give us any additional information of further TA you would find helpful related to this topic, other topical areas you would like more information, please let us know, and we do share this information with SAMHSA. And we'll just leave that up for a minute to let folks enter their suggestions to us. If you're not already subscribed to the listserv, this is the QR code and the shortened link where you can join the listserv. We've also put it in the chat for you. And we're just sharing the certificate of attendance one more time to give folks a chance to download that if they would like to have that for today. And next slide, please. This is our contact information at SAMHSA's Gaines Center. If you would like to contact us at any time for phone-based TA or any additional information that you would like, please, you can either phone us or go to the website to email us, and we would love to hear from you. And we'll just leave the chat open for a couple more minutes to give folks a chance to download that certificate if they would like it. And then for now, we will say goodbye for this afternoon, and thank you to everyone who joined us. And we look forward to seeing you at a future event.